Welcome to our June edition of the TB Think Tank webinar series. This session is titled TB Meningitis in Children, Global Estimates, Local Health Systems, and COVID-19. Please do engage, provide commentary, ask questions underneath the Q&A tab at the top right-hand corner of your screen. And we have 3 speakers for today, which I will introduce shortly. Our first speaker for today is Dr. Karen Dupree, who is a senior researcher at the Department of Pediatrics and Child Health at Stellenbosch University. She also leads the Pediatric TB Epidemiology and Implementation Science Research at the Desmond Tutu TB Center. Since joining the center, she has successfully completed an operational research fellowship at the Union, a distance learning MSc degree in epidemiology at the London School of Hygiene and Tropical Medicine, cum laude, and a PhD at Stellenbosch University. She has also been a member of the World Health Organization Child and Adolescent TB Working Group since 2012. Our second speaker is Dr. Victoria Namukuta, who received her MB CHB at Makerere University in Uganda and is currently enrolled for the MSc in Clinical Epidemiology at Stellenbosch University. Her MSc project is part of a larger study aiming to quantify the burden of pediatric TB meningitis in the Western Cape, under the supervision of Dr. Karen Dupree and Prof. Annika Hesseling. She also works with the Desmond Tutu TB Center, Department of Pediatrics and Child Health at Stellenbosch University. Her research interests include pediatric and peripartum TB epidemiology. And lastly, we have Zunisani Baloyi, who is a research psychologist with the Health Professions Council of South Africa. Since joining the Desmond Tutu TB Center in 2019, she has supported several projects at the center and is currently the lead social scientist for the Care for TB MKIT study. She has also contributed towards several publications and is currently working as a project manager for a longitudinal study exploring chronic illnesses and population-based surveillance. I will now hand over to our speakers for today. Thank you.
Thank you very much, Nolwazi. Just to give you feedback quickly on Zunisani is struggling a bit to join. She said she joined as a attendee, but not a presenter. So if you could maybe just, while I start with the presentation, if you can maybe just have a, can I share my slides? Is that fine? Nolwazi? Okay, thank you. How's that? Can everybody see that? Nolwazi, I'm assuming we can see that.
Yes, Karen, we can.
Thank you very much. Thank you very much for the beautiful introduction and the opportunities to tell the think tank members a little bit more about TB meningitis in children and a lot of the work that we as a team have been doing at the Desmond Tutu TB Center. So just to give you a quick overview of the talks, I'm going to start to just give a little bit of context, then I'll take you through the results of a modeling study where we estimated the burden of TBM in children globally. Then Zunisani will talk a little bit through the complex care pathways that these children have to navigate. And then Victoria will tell you a little bit more of the impact that COVID-19 had on children with TBM at Tygerberg Hospital. So I'm hoping that after this, the next couple of slides, that I can convince you that TBM in children really is a forgotten public health emergency. And it is something that deserves, it's a form of TB in children that really deserves a lot of attention. I'm sure all of you are familiar with this data from the latest WHO Global TB report, we estimate that approximately 1.25 million of children globally between the age 0 to 14 developed TB in 2022, and roughly about 214,000 TB deaths in this age group. So children, the youngest children, have a very high risk to progress to TB and TBM specifically when exposed and infected with Mycobacterium tuberculosis. And if we look at the natural history data, the risk is almost close to 20% in the younger children below 1, and then a little bit lower, but still quite high in the under 2s. We also know that the risk of progressing to TBM is usually the highest within the first 4 months following infection. TBM also often presents with non-specific and subtle signs, specifically during the early stages of disease. And these children don't come to the clinic with a typical meningitis symptoms that's really sort of easy to recognize, and that really poses some diagnostic difficulties. Then the disease stage at presentation, so their clinical staging, is associated with outcomes. So we typically would stage children clinically at diagnosis between stage 1, stage 2 is divided in 2 different stages, and A and B, and then stage 3. And a systematic review that I'll show you some results on now showed that nearly half of the patients, this was a global systematic review, presented with stage 3 TBM, which is really tragic because they have a very high risk of mortality and neurological neurodisability following their treatment if they survive, if they present at such a late stage of TBM disease. And there's multiple factors that influence the number of children who presents with TBM in a population. The population age structure influences this because of the wide-based population structure with a lot of young kids in the background of a high TB transmission area. There's a very high risk of, there's more children at risk to progress to TBM the younger they are at the time point of exposure or infection. But then importantly, our health system factors are also crucial because we know that BCG vaccination can prevent severe specifically disseminated and severe forms of TB, such as TB meningitis in children. And we also know that TB preventive therapy can prevent children from progressing to TB disease following exposure. So this is a systematic review, the CHOP study that I referred to earlier. This was done by a colleague from the US, published in 2014, and they looked at 19 studies and included more than 1,500 children. And in this review, they find across the board very high mortality of close to 20%, and substantial morbidity. So more than half of those children that survived had a risk of neurodisability. Then there's a study from Cape Town where Prof. Skuman and colleagues looked at long-term follow-up of these children. And it's this relatively small cohort, so only 76 children, but they followed them up. The median follow-up time was 6.5 years, but they followed some of them, I think, up to 10 years. And I think that's, for me, really sad, is that only 20% of these children were completely functionally normal at the time of follow-up. So they really carry a disproportionately high burden, not only of mortality, but also of morbidity once they develop TB meningitis. So as I said before, it's TB in children can often be a marker of how well our health systems are functioning. This was a study done by Prof. Solomons at Tygerberg Hospital, and he looked, it's also a small cohort, only 30 children at Tygerberg, but 60% of them presented with stage 3 TB meningitis. And I think for me, what's really important if we look at this is that there were tremendous diagnostic and treatment delays following presentation. So 70% of these children had potential TBM features and recent TB exposure at the time of their first healthcare visit. But the median number of healthcare visits before a diagnosis and admission to hospital was 4. Really just further delaying the diagnosis. Okay, so why is this a public health priority? I've shown you the extreme mortality and morbidity. It also places a substantial economic and social burden, not only on the families and the children, but also on our public health services. Not only in terms of the diagnostic process and the treatment, but also caring for these children afterwards and supporting all the disability, as well as the, supporting the family through caring for these children for the rest of their lives. And I think the other key thing for me is that it is preventable. And BCG has shown to protect up to 73% of children that is exposed to TB from developing TBM. And also in terms of TPT, we know that that is effective and safe and can significantly reduce the risk of TB disease progression. There's no estimate, so we don't have any idea how many children is affected by this devastating form of TB in children. Our surveillance data typically does not include TBM as an indicator. There's, as I said before, very non-specific subtle symptoms during early disease stages, which really culminates into all of these diagnostic delays, resulting in children presenting with advanced disease stage and then really poor outcomes. And then there's multiple missed opportunities where we could have presented this disease with BCG and TB preventive therapy. So all of these pressing facts led us, a couple of us, to really say we need to do something and we need to do better for children with TBM. And we wrote a grant and was funded to specifically look at not only the burden and outcomes of TBM in children, but also to think of opportunities for prevention, earlier diagnosis and treatment. And this large study sort of funded through the National Institutes of Health, and was a career development grant for myself with really contribution from a lot of amazing people around the world that supported me with this project. And within this large project, we had 3 aims. So the first aim was to model the global disease burden and mortality of TBM in children. Then there's a spatio-temporal analysis of TBM at a national level in South Africa, and then an aim to prospectively look at childhood TBM at a subnational level in the Western Cape province. And the presentations today will be covering the first and the third aim. So I'm now going to give you, tell you a little bit more about this study that we did, and then the other 2 presentations I will at the end link back again to the aim 3, so that you understand where it all fits in the bigger picture. So these results, the results I'm presenting now was also presented at the Union meeting last year, and is currently under review at the Lancet Global Health. And these are really the first estimates of children affected by TBM globally. I'm not going to go through the rationale again because I think we've covered that now in detail. So this is the conceptual framework of the model that we developed, and this is with a lot of help from other experts, because I'm not a modeler myself, but I've learned a lot. So the red boxes are the final modeled estimate. So we wanted to know how many children firstly developed TBM globally. Then we needed to, in terms of the outcomes, we needed to understand how many children do we think were treated for TBM or diagnosed and treated, and how many of these children were not treated. And then of those that were treated, how many would survive, right? And then of those that survive, how many would have neurological disability following treatment. So to do this, we needed input data. So all the yellow cylinders that you're seeing on here was input data, and the blue boxes were estimates that we could obtain from systematic reviews that's already in the literature. And if you look at the yellow cylinders, we use data from adult TB disease data and UN population estimates. We used HIV and BCG coverage estimates. We've used the WHO TB notifications, and we also used the WHO child TB case detection estimates at a country level in the model to help us determine this treated versus untreated ratio. The green blocks are parameters that we didn't have any robust estimates available for. So we therefore first had to go back to the literature to see where we can find the best possible data to inform all of these parameters. So we didn't know what is the risk of progression from infection specifically to TBM. As the initial studies that I told you about reported these estimates combined for TBM and miliary TB. We weren't sure, because there's no routine surveillance data for TBM, what the breakdown of the WHO TB notification should be. This case detection in TBM is likely different than case detection for overall TB. And then we also weren't sure what would be the relative rates in terms of morbidity and mortality by age. If we look at the methods, if you look here at the first, so the progression from infection to TBM, so the first green block at the left bottom, we wanted to know the risk of disease progression to TBM following infection. And for this, we used historical data from the pre-chemotherapy era. And these cohorts included children who were followed up over time after known TB exposure, and really provided the best, and I can probably say only, data to quantify the risk of TBM disease progression following infection by age. We used the data from 5 identified pre-chemotherapy studies that reported on TBM specifically, and completed a meta-analysis modeling the risk of TBM disease progression with age as a continuous variable. And as you can see from this meta-analysis results, the risk was quite consistently higher in the youngest children. For the second parameter, the proportion of notified childhood TB, that is TBM, we used a combined approach. So we obtained national routine TB data on TB and TBM by age from 33 countries. So 29 of those were from the ECDC, so the European CDC. And we obtained data from Brazil, USA, Ukraine, and South Africa. And in addition to this, we completed a literature review to identify any published studies that reported national pediatric data for TB and TBM by at least 2 age categories. We then synthesized all of this data to estimate the proportion of TB, that is TBM by age, using 4 distinct age categories. And this meta-analysis also found the highest risk in children younger than 1 year, as well as those 1 to 4 years of age. The last parameter we needed was risk ratios of TB mortality and morbidity by age. And from the pre-chemotherapy literature, we assumed 100% case fatality in untreated cases because of the severity of this disease. But the model parameters for mortality and morbidity were obtained from a systematic review and meta-analysis that was published and that I showed you earlier. But in this review, unfortunately, only produced those estimates in 1 age bracket, so for 0 to 14-year-olds. And in order to estimate our outcomes by age groups, we used the South African data just to inform risk ratios of the outcomes, because the South African data was the only data set that provided outcome data by age. So we looked at the distribution of mortality in the South African data set, and then we just assumed a similar distribution of the outcomes by age for our estimates in terms of mortality and morbidity. So this is the results from the systematic review that I'm referring to. And as you can see there at the bottom, they had a pooled risk of death of 19.3% and neurological sequelae among survivors of 53.9%. So our model estimated that in 2019, 24,000 children developed TBM globally, which means that we roughly think that this is the number of children every year that is diagnosed with TBM. This is not a once-off, it's an ongoing challenge. Approximately 2.5%, this only constitutes approximately 2.5% of the estimated TB burden. But 75% of these children were below the age of 5 years, and nearly 50% never received any treatment. If we look at the estimates by region, we also see that Africa and Southeast Asia carried the largest burden, but that is what we would expect if we look at the TB burden in those regions. Of the 24,000 children with TBM, we found, or we estimate that roughly just more than 16,000 children died. And this relates to a case fatality rate of 67% for TBM, which is almost 3.5 times higher, that of 3.5 times that of TB case fatality in children in general. Again, you'll see most deaths occurred in the under 5s, with more than 80% not receiving treatment. And again, as expected, Africa and Southeast Asia contributed the largest numbers of deaths. Amongst the close to 8,000 survivors, 5,500 children suffers with permanent neurological sequelae after their diagnosis of TBM in 2019. More than 2/3 of these children are younger than 5 years of age, and they have to live with permanent disability and increased healthcare needs following their TBM diagnosis. Today I've shown you the first estimates of how many children and their families are affected by this devastating form of TB in children. So we really need better diagnostics, more sensitive and specific diagnostics, as well as strong healthcare systems to facilitate early diagnosis and treatment to improve these outcomes. We also really need to make every effort possible to prevent this disease. We know BCG vaccination has a 73% efficacy to prevent and protect young children from TBM. And a recent systematic review showed us that TPT is effective following TB exposure. The effectiveness was 63% amongst all contacts. We really also need to strengthen our surveillance data and start reporting TBM in standard international reporting frameworks. And then we also need further research to better understand the costs both to the family and the healthcare system and society in general, as well as the long-term impact of this diagnosis on the child and their family post-TBM. And all of these are really critical elements to reduce not only the burden, but also mortality and morbidity of TBM in children. So this work would obviously not have been possible without continued support of an amazing team of mentors and colleagues, as well as country-level partners who contributed routine data, and of course the funders. So as I showed you, remember the slide from right in the beginning, if we think about the large study looking at TBM in children, I now want to share with you a little bit of what we've been doing the past 3 years in this specific AIM 3, looking at a sub-national level in the Western Cape province. So this is actually an amazing project where we brought together partners from across all different healthcare service levels, Department of Health researchers, to determine the incidence and case fatality rate of childhood TBM in the Western Cape. And we call the study Care for TBM Kids. And the fieldwork strategy of this study, we had 3 different components for the fieldwork. Firstly, we wanted to do large epidemiological surveillance of all pediatric TBM episodes in the Western Cape province. We then enrolled children into a nested observational cohort study, and at Tygerberg and Brooklyn Chest Hospital. In the end, we did not end, we could not recruit at Red Cross. And then we also wanted to measure the impact of COVID-19 on care for these children. And this was done in close collaboration with the Western Cape Provincial Health Data Centre, specifically Ms. Murray Smith, who's the data scientist, has really been amazing in moving all of this forward and really spending a lot of time to support this initiative. So I'm sure many of you are aware of the data center and sort of the unique ability in terms of surveillance that this provides. So they combine individual electronic health surveillance data from multiple sources, including hospital, clinics, pharmacies, laboratories, vital statistics, and then now electronic TB registers. And we use all of these data to inform or to be incorporated into an algorithm where we use the ICD-10 code for diagnosis. We looked at the laboratory in terms of biochemistry on the cerebrospinal fluid. We looked at the TB bacteriology, and then also treatment, specifically ethionamide, to determine or ascertain possible TBM cases in the Western Cape province. So Dunisani will present next on results from the observational cohort study. She will present work on the health systems, formative work she did initially, but there's also very exciting work that's coming forward in terms of the qualitative work within this cohort. And then Victoria will present some of the data that she's been working on to look at the impact of COVID-19 on care for children at Tygerberg. Thank you. So I'm handing over to Nisani.
We are still experiencing challenges with her joining, Karen. Is it somehow possible that we move
Maybe
over
Victoria.
to Victoria, please?
Yes, I think that is completely fine. Victoria?
Hi, can you hear me?
Yes, we can.
Okay, cool. I will share my slides just now. Okay. And then if you could just give me a thumbs up if you can see the slides, I will start.
We can see the slides. Thanks.
Awesome. Yes, so thank you so much for this opportunity to present this exciting data. As you've heard, I'm Victoria Namkuta, and I'm a Ugandan doctor currently pursuing my MSc in clinical epidemiology. And this aim, which is part of a larger study, we aim to look at the trends in the burden of TBM in children and the impact of the COVID-19 pandemic. And I'll give an introduction, and I will share our methods, preliminary findings, and some recommendations from those results. And so we know that TBM is the most severe form of TB disease in children. And following exposure, children less than 2 years or those living with HIV at the highest risk of progression to severe disease such as TBM. And this is associated with high mortality and morbidity, as Karen shared. Up to 20% of children die, and over half survive with neurological sequelae that are permanent. And there are diagnostic challenges as well with TBM because of the non-specific symptomatology of early disease. And we also know that TB disease in children is often post-bacillary. And so our best, we need to prioritize prevention and have a high index of suspicion for better outcomes for these children. We also know that BCG vaccination and TPT are effective in preventing and reducing TBM incidence, and they also function as great overall indicators of how well our health systems are functioning. TB incidence in children also reflects recent MTB transmission in the community and can also function as an indicator for TB disease in the overall TB disease in the community. And so from that, we definitely need routine surveillance data, as Karen shared. However, routine surveillance does not specifically report on TBM as an outcome. And yet, this data is important for monitoring disease trends and responding appropriately. And we move on to the effect of the COVID-19 pandemic on TB. From the 2021 Global TB Report, we know that COVID-19 disrupted TB services globally, with the first year-on-year increase in mortality and a decrease in the number of people that were diagnosed and treated for TB. And the most recent report, which is the 2023 Global TB Report, indicates that we are still recovering from the effects of the pandemic. And we see that in 2020, we had this drop in the number of incident TB cases, but we are recovering. And the incidence rate is now estimated to have increased by 3.9%, following a decline between 2010 and 2022. And when we also look at the deaths, we can see that there was an upward trend coinciding with the pandemic, following a steady downward trend from 2010 to 2022. So we are on our way to getting back on track. And when we also look at the effect of TBM on access to TPT, we see that there was a reduced access to TPT in the years during the pandemic, that's 2020 and 2021, but we're recovering, and the most recent numbers in 2022 show that there are more people that are accessing TPT. And when we look at this table, it's a modeling study looking at the impact of COVID-19 on childhood TB, and we see that there was a reduction in the notifications of children who with childhood TB during the pandemic. So overall, because there are no estimates of the burden of TBM in children, little can be said about the effect of COVID-19 and its associated restrictive measures on the burden and spectrum of pediatric TB. And without numbers, little can be said about the effect of COVID-19 on pediatric TBM. Therefore, this study set out to determine the burden of TBM and to investigate the impact of the pandemic on the burden, disease severity, and prevention of TBM in children at Tygerberg Hospital. We'll move on to the methods. It was a retrospective cohort study comparing prevention, disease severity, and outcomes of childhood TBM before, that is from 2017 to February 2020, and during, that is March 2020 to 2021, the COVID-19 pandemic. And this was conducted at Tygerberg Hospital. And we included children less than or equal to 13 years identified with TBM at Tygerberg during the study period. We used integrated electronic health data from the Provincial Health Data Center through an algorithm that combined biochemistry, microbiological, clinical ICD-10 codes, and pharmacology data to identify children with possible TBM. And these were clinically reviewed and verified to confirm the diagnosis. And when we look at the results overall, we were able to identify 263 children. The data collection was completed in May 2024. And when the data was reviewed, we identified 392 possible TBM episodes, out of which we confirmed 263 during the study period. And from this graph, you can see a trend from 2017 to 2021 with a drop between 2019 and 2020 and all the way up to 2021, coinciding with the onset of the COVID-19 pandemic. And to the right, we see an age disaggregated graph of the same data. And notably, while the biggest drop was seen in children 0 to 2 years old, however, generally there was a downward trend in the number of children with TBM at TBH between 2017 and 2021. And when we look at the demographic characteristics, to 2/3 of the children were less than 5 years old, and their median age was 2.2, and in a quartile range of 1.1 to 5.1 years, and 48.3% were male. Approximately 20% of children less than 5 years were severely underweight. Notably, children who presented during the COVID-19 pandemic tended to be older than those who presented before the pandemic. And when we move to the clinical characteristics, we see that 17 children were living with HIV throughout the study period. And there was also a significant association between HIV and the COVID-19 pandemic. And when we look at TBM staging at admission, 30% of the children presented with stage 3 disease, and of about half had advanced disease at diagnosis, and this is stage 2B and stage 3 disease. And of the children who had available data, only 137, that's 64.6%, had documented evidence of BCG vaccination. And notably, we see that 20% did not have any information recorded about BCG. And from this, we see we couldn't tell whether they had received BCG or not. And when just to explain, documented evidence of BCG vaccination included notes detailing confirmation of BCG vaccination or immunization up to date, or the presence of a BCG scar. And when we look at TB exposure, this was documented in 100 of the 263 children. However, only 10 of the 81 eligible children were initiated on TPT, which is quite low. When we look at the early in hospital and treatment outcomes, we see that 13 children died in hospital, which puts our in-hospital mortality at 4.9%. And of those that survived, most were either referred to a TB hospital or home-based care for further treatment. And we see here as well that referrals to the TB hospital were significantly less during the pandemic than before. And overall, we see that there was a higher mortality by the end of treatment compared to in-hospital mortality. When we look at that figure, we see that 30 children died by the end of treatment, and we are still exploring the treatment outcomes, and soon we'll be able to report out the results for those. We did perform univariable analysis for some of the outcomes, and overall, there were no significant differences in TBM disease severity, BCG vaccination status, or TPT initiation between the two time periods. However, as we've already seen, age and HIV were significantly associated with the COVID-19 pandemic. We are still busy with more in-depth analysis, and that will look at the difference in trends, that will explore variable analysis, and specifically look at treatment outcomes, exploring survival analysis in terms of timing of death across the two cohorts, and we should be able to share that data soon. Overall, admissions for TBM at Tagabak Hospital decreased during the COVID-19 pandemic, and preliminary analysis found a significant association with age and HIV status. Disease stage at presentation and in-hospital mortality was similar across the study groups, the cohorts. Notably, we identified many missed opportunities to prevent TBM, both before and during the pandemic. And these are BCG vaccination and TPT initiation for children who had been exposed to TB. And thus, we can conclude and say that increasing BCG coverage and TB contact management should be a priority for children with TBM, because we know that the treatment outcomes are really poor for these children. And as I mentioned, data analysis is still ongoing. These data are preliminary. We're still analyzing, and we should be able to share final results by the end of July or early August this year. I would like to acknowledge funding from NIH and Mariette Smith from the PHDC was helped out with the data. Tunisani and Danita, who are part of the study team, and the participants and their families. Thank you so much for listening.
Thank you so much, Dr. Victoria, for your presentation. So we are still experiencing challenges, Karen and Victoria, with our third presenter. So how would you like to proceed in that regard?
Otherwise, Nolwazi, I might not do it complete justice, but I can go through Tunisani's slides. So I think let's just proceed that way, if that's fine.
Okay.
But yeah, because this is now, I've seen that obviously I was part of the work, but yeah. So I'll take you through what she sort of prepared for today. Okay.
All right. Thank you so much.
Pleasure. So as Nolwazi said, Tunisani is a research psychologist who has been working with us on this study for the past 3 years. And this was really the results of the formative work that she did to better understand what is sort of happening in terms of the back context for these children. How do they navigate the health systems? So we've gone through all of the rationale. So the aim of this part was really to describe the health systems at both primary and hospital level care, and to present healthcare workers' perspectives on the barriers that impact the patient's progress along the pathway. And maybe just also to say that in the subsequent work within the cohort, we also interviewed our families. So this is sort of the initial part, just hearing what the healthcare workers thought. So this research included observations at hospitals as well as primary healthcare facilities, and as well as in-depth interviews with 17 healthcare workers. And data was then analysed through a case descriptive analysis. And really drawing on the informant interviews and observations, we want to highlight in this presentation the complexity of the health pathways and health systems that these children have to navigate, and then also just highlight some of the barriers that we identified that prevent progression into care. So children with probable TBM symptoms must navigate really a complex health system that is not linear. And I think from here it just helps us to understand a little bit how these children and their families, who often the caregiver is also ill, from starting at home pre-diagnosis, going to other healthcare providers or seeking care at the primary healthcare facility, and then once they are identified as with possible TBM, they would be referred to a hospital to receive diagnostic imaging and supportive care. And then from there, they are either referred to back to the primary healthcare in terms of a home-based home-based care treatment program, where they then get the treatment at the hospital, followed up at the hospital, but they go home, or they're discharged to a specialized TB hospital. And then when they go home, they actually, and we didn't even include that, but if you think of all the different auxiliary health services that are part of the post-TBM treatment process for these children, it's really an additional network of services that they need to access. As you saw on the figure, we tried to group the barriers into different sections. So pre-admission and primary care hospital barriers, post-admission and post-discharge barriers, and then COVID-19 related challenges. So in terms of the pre-admission and primary care barriers, the sort of burden of facilities and time constraints for the healthcare workers was a real problem. This is a quote from one of the district managers. saying that the healthcare workers experience challenges when clinics are full of patients, and screening really just becomes a mundane task to complete a tick box, and that they sometimes, don't necessarily identify the danger or risk signs. And I think this we often see in terms of, history, and specifically because of the nature of presentation with TBM, where these children don't present as acutely ill as other meningitis cases. Then also limited post-training, mentorship for the healthcare workers to really recognize the early symptoms, because they really need a high index of suspicion to identify these children up front. And I think also often these kids, when they're brought back, they don't necessarily see the same healthcare worker. So to really make sure that all of the healthcare workers understand the importance of follow-up and good documentation, so that if the child comes back and they're not better, that they can be escalated to the next level of care. At hospital level, the referral pathways between primary healthcare and hospital was a challenge. Sometimes the nurses struggle to get patients referred, and also transport we've noticed that transport between the healthcare facilities are always not necessarily ideal. In terms of treatment, there's really still a lot that can be done for the palatability and the availability of child-friendly formulations. Specifically for TBM, we make use of one of the FTCs, but we have to dose differently with PZA and ethionamide. So, and there's definitely challenges dosing the younger, smaller kids with adult sort of formulations when we don't have the right dosage formulations. Then in terms of post-discharge, there's really limited post-rehabilitation services, and specifically to families that is often that comes from a poor socioeconomic background, and it's really difficult for them, even if the services are available at hospital level, but to travel the distance to the hospital on a regular basis to access these services are problematic. In terms of COVID-19, there were problems with making appointments and the patients having to wait sometimes for a long time to be assisted, and then they're being turned away. Then, as we all know, resources during COVID-19 was also redirected to sort of other facilities and other prioritized to go towards other care departments. So that really, within this complex health system diagram we've shown you, COVID, I think, just complicated that. In terms of our recommendations, we really think that it's important to really have compulsory and regular training, not only on TB, but on TB in general in children. We can really work on improving our communication between the different levels of healthcare, and maybe structuring algorithms to outline referral criteria for patients with possible TBM at both primary healthcare and district level care could help the clinicians to navigate that process of referral, and just to structure that better. And then having an integrated data system with alert functions that really could flag to the healthcare worker that this is sort of the second, third, or fourth visit of this child in the past 2 or 3 months. And yes, as this is also really a work of a large number of people that contributed to it. And obviously, we want to thank the entire team, Department of Health and their support, all the City of Cape Town staff, and then the funders.
Thank you so much, Karen. And again, thank you to our speakers for today. Whilst we wait for people to put in their questions or comments, do you perhaps have any remarks, comments to add, whether from Victoria or Karen, or as well, we see you have your colleague online as well, Julie. So if any of you guys have any comments or remarks whilst we wait for people's comments to come in or questions.
Thanks, Nolwazi. Julie, it would be great to just hear your input perhaps on this work and just from being in the field and really seeing the consequences of this diagnosis.
Thanks.
And if possible, please switch on your camera, Julie, if possible, please. Thank you so much.
Hi, thanks so much, Corin and Victoria. It always feels like you're talking amongst friends when you're talking about the sort of the orphan of the orphans, right? The TBM amongst the TBM kids. So thank you so much for putting that through, and a pity that we couldn't get Zunisani's very excellent work. I've seen her present that. It's not really a question or a comment. I guess maybe, Corin, maybe you'd have an idea on how we could fix this. But one of the concerns that I have is that when we report children who've got TB meningitis and pulmonary TB, according to the WHO guidelines, those children get reported as pulmonary. So my understanding is that that's because in adults, somebody with pulmonary TB is an infection risk. So that's why we really want to know where those patients are. But do you think that we perhaps the picture's even worse than we realize, because we're capturing some kids who've got both as pulmonary TB and they're not even being picked up as TBMs, even though they're being treated for TBM, they're not being notified for that. And what do you think would be a good way for us to get around that? I mean, I've often wanted to just cheat and notify the child as TBM because that's actually the stat that I care about. But what do you think about that?
Thanks, Julie. I think that's an excellent question, and it really just speaks to the need for better surveillance systems, right? I think personally, I don't know if you remember, but long ago, the WHO originally asked us to report on spectrum of disease was reported in pulmonary TB, extrapulmonary TB, or both PTB and EPTB, which I think was even at that point, helpful. But I do think that the important thing will be for this to come up as an indicator, to be pressed, that we actually report this in terms of, the spectrum of the severe forms of TB disease, and sort of maybe add a way to really report on these severe forms of TB. And I think something like spinal TB or miliary TB, deserves sort of the same type of attention from all of us. And I think it would be good to hear. I mean, we've been engaging in lots of conversations about this. But you're completely correct. The WHO changed their spectrum definition so it's PTB with or without EPTB, or EPTB on its own, but it actually misses a lot of the extrapulmonary TB by categorizing it like that. And I'm actually, it's a bit of a shame that they've changed that, because, the three categories captured, more detailed information. But even if it was in the old categories, we're still not, we won't see how many of those actually TBM cases. The good thing, though, is that our modeling work, I think, would hopefully raise some awareness, because that was not relying on notifications within the routine data itself. It was looking sort of from the natural history disease progression approach. But I know you also are a strong advocate for better care and better services. And I think it's really heartbreaking sometimes, the stories we see as clinicians when children, fell through many cracks and then end up with a diagnosis of TB meningitis.
Yeah, I think what I'm also sort of nervous of, I mean, the WhatsApp I got this morning was from a doctor who's got a child who's got TB meningitis, and they don't have any ethionamide in his facility to treat the child. So I think that getting those notifications correct also helps us to make sure that we're ordering the correct medications. And that's a dedicated clinician who's going the extra mile to try and find some of the medicine he needs. But I think, unfortunately, the kids are falling out of cracks before they get diagnosed and even after they get diagnosed. When in lots of parts of the country, once the child is stable, they get referred to a primary healthcare facility. They never get seen by a doctor again. These are not people who are necessarily comfortable doing a neurological examination on a child. And if you've already jumped through the few hoops of getting diagnosed, getting started on treatment, it's really a shame if at the end we just don't have the medicines for you, or you get managed by somebody who's not really comfortable managing your quite complicated disease. And something that I learned from Prof. Donald, and I think this really stuck with me, is that the kids with TBM who you have to pay the most attention to is the healthy kids. The kids who maybe had a headache, maybe they had a seizure, but once you started them on treatment, they're fine and they can go back to school and they're actually fine. Because those are the kids where the parents they don't really see the point of giving them this horrible medication, and they think, oh, my child's fine, I can stop the treatment after 4 months. The child who's got significant neurological fallout and can't swallow and is still lying in hospital, even if you treat the TB, you're not going to change that child's life. So just a mind shift of actually your priority patients are the mild TBs, because you can buy a great future for that child if you just get the first 6 months right.
Thank you, Julie. Nolbozi, do we have
We don't have any comments yet.
There's one comment I see here. I think from my side, offline electronic booking systems. Oh, you did ask, please elaborate.
Yes.
Yeah, it'd be good to hear exactly what that participant was alluding to.
So, colleagues, with just 4 minutes left, please do still enter your questions or comments under the Q&A tab. Okay, we have extra information on the question. So, speakers, the question or the comment rather is the electronic booking system is affected by network. So this person struggled to book online for follow-ups and then had to book manually.
And is this, I guess, is this from a healthcare worker or from a, or not from, because probably not a patient? It would be interesting.
Yes, of course, yes.
Yeah, I can just imagine that is challenging, because it also makes it very much or very difficult to then see whether your follow-ups did not come back, right? And Julie, I mean, you know how we always struggle to make sure that all our follow-ups, if we do home-based care, come back for our follow-ups, right? Because I think that's one thing. A lot of these kids can be treated at home, but you need to make sure that they're seen every month and that they're doing okay and that they're taking their treatment. So I'm sure that can be a problem. I don't know, Julie, if you've got any sort of suggestions in terms of the comment.
Well, I think it's very much about what you have locally available. But I think the comment came from somebody in the Eastern Cape, and there's actually quite a strong Eastern Cape practical group for some of the peds clinics. Somebody added me to that, and you know the comments that are on there are often like, hi everyone, can't get hold of this CHC, please can somebody on this group get hold of me if you're working there. So I think, you know, the electronic systems are nice, but having some sort of a backup that's either WhatsApp based or telephone based really works. The one thing that I definitely do not think works, and it's very common in lots of the hospitals, is saying we'll phone the patient back with the dates. So especially at the end of the year, when lots of clinics don't have their diaries, and you see your patient in November and you say we need to see you again in January, but the secretary doesn't have the January diary yet, so she says she'll phone the family back with the date. I think that's a surefire way to start using patients. So I think it is important as well to really make sure that you know exactly which date that person's coming back before they leave the clinic. And with the booking system, I mean, I do think the old-fashioned picking up the phone, WhatsApping somebody is helpful, but ideally you really don't want the patient to leave your sites before you've got that confirmation.
Thank you so much, Julie. So we do have one question, our speakers. So the question then asks, do we know what the reasons are for the lower number of cases in the COVID period?
That's from Salome. That is a very good question, Salome. Victoria, and you're welcome also to jump in here, but maybe just to give a thought. So no, we are not exactly sure why, and that is sort of part of, I mean, clinically we saw less admissions, and that's why we started the research and asked the questions. And I think we were all expecting to see sicker kids, like at most, you know, more severe advanced disease stage, and that was maybe a reflection of the healthcare systems that was affected during COVID. So it was quite interesting for me when we did the analysis now that we actually did not find that. And we are still sort of contemplating to try and see. What's very strange for me is it looks like it's the younger kids without HIV that had less TBM, right, during COVID. And whether that was transmission risk or what happened there, we're not 100% sure yet. And we're still trying to figure that out. But it's a great question. I mean, there's lots of people, it's really like a difficult topic to think about. How did our measures to curb COVID impacted on our transmission on TB? We know from the prevalence survey that it probably didn't have a big impact local at the community level, but it might have had an impact at a household level. I don't know. There's lots of interesting questions there that we still don't know. Victoria, did you want to add anything there, or Julie?
No, thanks, Karen. I think you've captured my thoughts as well quite succinctly. Was quite interesting to see those downward trends, and I think it's worth thinking about it more and trying to come up with plausible answers. I'm not sure how far we'll get, but maybe Julie can pitch in as a clinician.
Yeah, I certainly don't have answers for the data, but I do remember working in a TB hospital at that time. And during COVID, what was very concerning to us is we suddenly had very few patients of any kind. So a very full ward was suddenly reduced to very few. So we know less kids were coming in. And just anecdotally, straight after the first lockdown, that was the worst TBM patients I've ever seen. You know, it was really lots of kids in comas, lots of kids who were incredibly severe. So I suspect that a lot of kids presented later or died, and you know, we only caught them once they were really quite bad. And you know, the stats won't show you that. The stats say it was a TBM, but I think a lot of kids died from TBM at that stage, and you know, maybe they would have been picked up earlier if there were more clinics open, if people weren't so scared to go to facilities and so on. But that's very anecdotal. That's my experience from one hospital.
Thank you so much, Julie. We are 2 minutes over time, and thank you for your patience. I'd like to thank our speakers again for their time in presenting today, as well as everyone in attendance. And please do join us next month on the 15th of July for our session, which is titled Bedaquiline Surveillance Using Routine Laboratory Data, South Africa. And if you'd like to see yourself on this very platform in the coming months, please do email myself at ngosi@tbthinktank.org. And please do enjoy the rest of your Monday afternoon. Bye.
Bye, everyone.